Good morning. First of all, I feel it's a great privilege and honor for me to present before this August audience. In fact, when I was called by Sri Chakrapani about 10 days back, I was surprised when I got his call. He told me that he has heard about General Hospital Ernakulam and he wants me to make a presentation here in this conference. Even though I was surprised and I felt proud also, because for a hospital in Kerala to be acknowledged by such a center and to present before such an audience is a real honor also. Anyway, I'll just go into my topic. There is a General Hospital Ernakulam. It is a journey towards quality. It's a government hospital. This is an overview of the hospital. And this is the first hospital in the state to get NABH accreditation. In fact, this is one of the biggest hospitals in the country to get NABH accreditation. This is a multi-specialty hospital. This started about 170 years back. It was started by the British. And now the bed strength is about 783 and it is the highest among the hospitals in Kerala Health Service. That is the biggest hospital in the Kerala Health Services. And we cater to the nearby districts, and this is the only hospital with facilities to treat cancer patients in the state. So this is the basic hospital statistics. The bed strength is 783, average OP per day is 2000 to 2500. Average admissions per day 80 to 100 with a bed occupancy rate of 70% plus, and a daily delivery rate varies between 8 to 10. And this NABH project in the hospital, it was started in 2008. In fact, there were 19 hospitals selected by the state government to start this NABH process, and we were one of it. And actually, this is the only hospital among all the 19 hospitals who have got the NABH accreditation. Initially, when we started the NABH accreditation, when we were told by the government that you had to go into the process for NABH accreditation, all of us were very skeptical, including myself. For a government hospital to go for NABH accreditation, it was just like a pipe dream. It cannot be materialized. That was the basic thinking which we had. Then gradually we had a good team in the higher up, right from the health minister, and we started the process. And being the nodal officer at that time, I put this idea in front of the staff of our hospital. And the reaction I got from the staff was totally negative. Maybe about, we had 1000 plus staff in the hospital, maybe about 2%, just about 2%, they received the idea with some smile, but all the others, they were least interested, least bothered. This is not something to be happening in a government hospital, we cannot do it. Anyway, we took it as a challenge. I had some core team members with me. We took it as a challenge and we started the process. And this, our journey for quality started. And as you know, quality is a journey, not a destination. And it meets or exceeds one's expectation. That is the main motto in which we had, and we started the journey. And the process started in October 2008. And initially what we did was we identified the gaps in the hospital. Sorry. NABH has got its chapters, its elements. So with that we identified the gaps, we analyzed and we divided into A, B, C level, 3 levels. And we started with set plans for the hospital. Just like any government hospital in the state, this is the basic picture. I will give you some pictures of the hospital which we had the pre-NABH era. These were the various wards during that time. And as you see, from this, we had to start our NABH process. And with a determined few, we started our journey towards excellence. and we had various programs. And one thing we practiced was we never ordered or commanded to do some things. We just asked them whether you could do. It was only by pursuance and friendly approach we could approach the staff, because as you know, Kerala is a very volatile state with trade unionism. To impose something is very difficult in Kerala. So if you start imposing, the next day we are exposed and we are outside. So we had to go on a pursuant way, and that is how we started the whole journey. And these are the strategies we adopted. We had various new constructions done, continuous training of staff. This was very important, and this was done frequently. And we had a very dependable and committed training staff for the trainers for the staff. And there are the NRHM, the National Rural Health Mission, supplied us additional staff, and there is a hospital development society chaired by the district collector. With that also we had additional staff. Infection control practices, Safe program. That is a program which was started in the state by Indian Academy of Pediatrics along with NRHM. It is about the safe injection practice, safe infusion practice, and safe disposal. And now Safe practice has become mandatory for Safe certification has become mandatory for NABH. Unless you get Safe certification, you will not, you cannot go for NABH accreditation. That is the latest from NABH. But this was something which we had started. We with Indian Academy of Pediatrics, we started the Safe practice and hygienic hospital environment, and we had done health checkup for all the employees with an emergency preparedness plan. Various all these heads were allotted to various persons, and various committees were formed. Like team building and committee formation, we developed manuals and SOPs, continuous sensitization of the staff, implementation of quality and safety practices, corrective and preventive action based on the root cause analysis and audits, renovation, construction and relocation required areas, periodic benchmark of the indicators, setting hospital in the continuous quality management. All these things were done. Why I am saying this? Because this was something which we cannot imagine in a government setup. A government setup, what normally happens, patients come, doctors treat, doctors give some medicine, they may write medicine, in the daily rounds, they may write something, scribble something. That was the practice which was being followed. And to adopt these strategies, a great deal of effort was needed, great deal of cooperation was needed from all the staff, and we got it. That is the main advantage which we got. And the sensitization programs, call to actions committees were all formed. So the journey was still continuing. And the various committees were constituted. For each and every aspect, every work being done in the hospital, various committees were constituted, like biomedical equipment safety committee, blood bank, clinical risk, code blue, condemnation core committee, disaster management. Like this, we are about 18 committees were formed in the hospital. And all these committees, we made a calendar which meets every month we are supposed to meet. So that calendar was made. The dictum was, even if only one member is present, the committee should meet. That was the dictum. So the meeting was going on. The daily, whatever, one or two members were, they discussed, prepared a minutes. So that process went on. And again, we developed signage and display for public information system. Various signages. The hospital, if you visit the hospital, you can see the hospital is flooded with signages. Whatever somebody who comes to the hospital, they want to know, they will be able to know from the signages. Which included the mission and vision, services available and services not available. That is also mentioned there. Organization chart, layout. Then the crowd management, that is a big problem. We made a new OP waiting area. That is a new OP waiting area, and we started the evening OP because there are the outpatient department functions normally only from 8 to 1. After this, we started an evening OP, that from 2 to 8. Another OP sessions were started, and the security was strengthened. Initially, we had male security. So we thought in the male security, we could not get a good result from them, so we appointed females. Kudumbasri workers are there in Kerala, and monetarily also in the hospital, because we take 1 rupee from the visitors who come to the hospital. When the male security were there, we are getting about 800 rupees to 1000 rupees per day. Once the female set in, we started getting 4000 to 5000 per day. So, so that was a. Now the other hospitals are also adopting this policy of appointing women as security. And the basic amenities, waiting chairs, fans, proper lighting, cafeteria, televisions for the public, ensuring patient privacy, curtains in the ICUs, patient information reception counter, RSBY counter, signages, PA system. These are all initiated, and these are the pharmacy where the medicines were properly arranged. There is the look-alike, sound-alike medicine, they have to be properly arranged. 24-hour pharmacy was started, and the hospital drug formulary also was started. Then the wards were rearranged, crash carts in ICU, emergency medicines were made available, and daily sanitation rounds and audit fortnightly was being done. And this is one signage where we give the mission and vision of the hospital. In fact, this is given in 2 languages, both Malayalam and English. It is being exhibited. And the various manuals were prepared for all activities in the hospital. Various manuals were prepared, and it was distributed to all the wards. In all wards, you can see all the manuals and standard operating procedures. The SOPs were there in all the hospitals. And she was the superintendent that time, and is the NRHM district program manager. So we started giving these manuals for all the wards. These are the various signages. This is the hospital general signage, and this is a flow chart of the staff. And as I said earlier, the awareness and training programs, it was very frequent. Staff nurses, attendants, all the staff, right from doctors. And I can say initially it started on the doctors, and we got the maximum resistance from the doctors. The doctors were the people who gave the maximum resistance. But in the end, the doctors are the people who are in the front now. Because once we achieved the accreditation, now we feel that, anyway, I'll come to that later. These are the various training programs going on in the hospital: ventilator training, fire extinguisher training. This is a fire safety, one mock drill was conducted. CPR training. Again, mock drills in code blue, code pink, code orange. All these were conducted, mock drills were conducted. This is another scene of the mock drills being conducted. This is one child abduction. Again, everything. There's a triage area where we conduct the mock drill. Personal health checkup of the all the staff. All staff were those who are not vaccinated. They were given hepatitis B vaccination. And the main thing which we found, one, absence of written policies and procedures for healthcare delivery were there. We prepared the manuals, policies and procedures. Staff shortage in various categories, and the recruitment of additional staff. Proper sanitation and cleanliness, sanitation made effective. Poor signage, we made more signages. Absence of audit on all aspects, and corrective and preventive measures were taken based on audit and survey. Lack of awareness about patients' rights and responsibilities. Signages on patients' rights and responsibilities. There is a citizen charter for the hospital which we give all the inpatient, all the patients who are admitted, we give that citizen charter. Calibration of all the equipments were done. Reporting of adverse events, needle stick injury, where we went for the audit and root cause analysis. Security system, again, as I said, it was strengthened by using the female security persons. And there are no parameter for patient safety where we have done trainings and mock drills. Thus, the transformation of quality care, the journey was still continuing. This is the admission counter which we have presently. This along with the RSBY counter, it is being functioning. And these are the staff appointed by the Hospital Development Society. Then they have that is the uniform which they are having. This is another view of them. And the whole hospital, the whole thing is computerized, right from outpatient registration till the discharge, everything is computerized. We have got a system prepared by NIC, National Informatics Center. This is the OP, outpatient waiting area, which was not there previously. Again, the OP waiting inside area. And we have got a token system whereby when they register in the outpatient department itself, the token number is generated for the individual OP. Whichever OP they want to go, that token number will be generated when they register in the outpatient department. This is the dental OP, which is in fact incidentally an air-conditioned dental outpatient department. This is the casualty block. Earlier, the casualty, I have not taken a picture of the earlier one, but this is the new casualty block which we have. These are the various wards which I think I had shown you some pictures of the wards earlier. Now, these are how the wards are looking like at present. And in fact, we got money from the government, we got sponsors, the Lions Club, Rotary Club, all those sponsors, they joined with us to renovate the hospital. Again, these are the new wards. In fact, basically these are all, this is the newly constructed ward, but these are all renovated wards. And various high dependency areas were developed in the hospital. That is a medical intensive care unit, intensive coronary care unit, and neonatal ICU. And there is a this is a burns ICU, surgical ICU is there, and we have got a burns intensive care unit. This is the intensive coronary care unit. This is the neonatal intensive care unit. Another picture of that. Here it's a level 2 center where we keep 10 babies at a time. We can keep 10 babies at a time. This is a surgical intensive care unit where all the patients post-operative, they are kept there for 24 hours, then they are sent to the wards. These are the nurses, they have been specially trained for once we went for the NABH accreditation. Because nursing care is very important as part of the NABH accreditation. These are the operation theaters. Earlier, we had multiple tables in one operation theater. Now that has been changed. There is one theater with a single table, and it's a centrally air conditioned with HEPA filter. Everything is there. This is one operation theater. This is a laboratory where we have a laboratory, 24-hour laboratory we have, where we do all the major tests are being done there. We have got around 23 lab technicians working there around the clock. So a fully automated laboratory. The histopathology department. This is the CSSD department. This is a laparoscopic surgery. There are surgeons who are doing laparoscopic surgeries there. This is the imaging service. We got CT scan, we have got mammography unit, and we have got digitalized X-ray system. It's in fact the first time in the government sector we are having a digitalized X-ray system there in the hospital. The CT scan, the OPG machine for dental department. As I said earlier, we have got this treatment facilities for oncology patients. This is a brachytherapy unit whereby we treat for cervical cancer. This is the main telecobalt unit. We have got 2 telecobalt units which are being used, and on average we are giving about radiation to about 60 to 70 patients per day, and chemotherapy is also being given to around almost similar number every day. A 24-hour blood bank, the pharmacy counter. This is the medicine arranged, as I said, medicines arranged very systematically. This outpatient medical record. Previously, we were having bundles of papers where we have, the inpatients, we used to get some bundles of papers. Now we have made a definite filing system is there. It's all computerized. So, and we give a card for all the inpatients who get, all the patients who get admitted. And we have started a dietary kitchen in the hospital, whereby we give all 3 meals of the day, along with evening tea and snacks for all the patients on their bedside. And they don't have to wash the plates even. It is being brought back to the kitchen, where we have got a big washing area. This is our health minister who is inaugurating the dietary kitchen. These are the kitchen area. Here also we have appointed this Kudumbasri ladies. This on these trolleys they take the food to various wards. This is how we serve the food. We have got 5 dietitians who prepare the diets for the patient. We give 5 different types of diets: normal diet, high protein diet, salt restricted diet, sugar diabetic diet. So this is being advised by the dietitians. These are the trolley where they carry the food. These are the ladies who daily take it to the wards. This is how the food is being given to the patient. They take the food, they keep the plates there. The plates are being brought back and is being washed in the kitchen itself. And for bystanders, we give food. These are also all this dietary kitchen and this bystanders food are totally sponsored. Whoever comes to the hospital, we ask them for money. Suppose somebody comes to invite for a wedding, we say on that day give us 1 day's lunch or 1 day's dinner. So that is how we get the money for this dietary system. No government money we get for this. All the money is totally sponsored. The general public, they give us. Only thing, we go to them with a begging bowl, and people are ready to give the money. No, till now we have not faced any problem with that. And this is a bystanders dormitory where the bystanders, they sleep at night. So this is a dormitory being provided to the bystanders. This is a relaxing area for the bystanders. This is the power laundry which we have. And we have yoga therapy in our psychiatric department. In fact, this is our psychiatrist and this is the yoga master. And especially for the de-addiction patients, we give this yoga therapy. And this is a mortuary or cold room where we can keep 20 bodies at a time. This is a cold room, not a mobile freezer compartment. We can keep 20 bodies at a time. In case if needed, we can keep more bodies on the floor also, because last year in Sabarimala there was a big tragedy where more than 30 people died. And all those people were brought here from Sabarimala to our hospital for embalming and postmortem. So with this we could keep all the bodies there. Only by the next day the flights could be arranged and they could be sent. In fact, most of them were from Tamil Nadu and Karnataka. They were sent by flight. So with this we could keep almost 30 bodies in the cold room. This is an advanced life support ambulance which we have. And we have got a palliative care unit where we have got 3 home care units. They go to on a daily basis, they are going to going for house visits, and we have got a palliative care training center also. And this is a gender-based management center where they're also especially for ladies, basically meant for ladies who get gender-based violence attacks on them. They come there, they get counseling or whatever is need to be done is being done for them. This is a police aid post which we have. These are as I told you about the security people, the ladies. They are very strict there, these ladies. Now, the early administrative office I had shown, this is the superintendent's room. This is the main administrative office. We have made it like a IT office. Again, another picture of the main administrative office. This is the conference hall where we can accommodate at least around 300 people in the conference hall. And we got a good telemedicine unit also, whereby we communicate with almost all the hospitals and in the state, including medical colleges and Lakshadweep also. So this is one conference which we are having with another general hospital in Pathanamthitta. And these are the various awards which we received. First, and the foremost is the NABH accreditation. Then certificate of compliance from QCA Essential Standard Program for Medical Laboratories, Baby Friendly Hospital Initiative, that is for the breastfeeding practices, award from Pollution Control Board. In fact, this year 2012 we got the award for the best hospital in the government sector for from Pollution Control Board. And in fact, we were given 1 crore rupee by the Pollution Control Board as an award to start a new STP plant in the hospital. Safe Air certification, and one of our nurses received the Florence Nightingale Award for Best South Indian Nurse. And this is the proudest moment which we had, that is the NABH accreditation, which we received in 2011 February from Delhi. This is a certificate of compliance for the laboratories, Baby Friendly Hospital, Pollution Control Board Award, Safe Air certification, the various awards. And the hospital compound has been beautified with the support from Cochin Refineries, and the very good lawn is there, with a garden is there. This is another view. And the ongoing projects in the hospital, we are already ordered for an MRI scan. In fact, that meeting was held yesterday. Dialysis unit is going to come up with about 12 dialysis units is going to come up next. In fact, it is going to be inaugurated next week. OP building extension, sewage treatment plant, a new canteen is being done, asset maintenance work is done. And the next our dream project is the super specialty services to be introduced, which is not there in the government services now. This is in brief what we have done for the from 2008 to 2011. And before I conclude, for a government hospital to go for such an ambitious thing itself, I can say it is an over-ambitious thinking. But with the support of cooperation from all the staff and from the government, we could achieve this. And because of that, I am right in front of you to present this. Thank you very much. Thank you.